I'm with Cindy Sneed, the Chief Clinical Officer of the Next Door, located in Nashville. And I had asked Cindy to meet with me today and answer a few questions about the Next Door. And Cindy, perhaps you can tell us a little bit about the history of the Next Door, its mission, some of the successes and challenges.
Okay, thanks, Chris.
Mm-hmm.
The Next Door is a 6-month transitional living facility located in downtown Nashville. Primarily was developed to address the needs of women coming out of incarceration settings. In that 6-month program, we address things such as life skills, psychiatric care, mental health assessments, co-occurring disorder assessment and treatment, and 100% of the women that come to the Next Door have endorsed substance addictions. About 70 to 75% of those same women will also meet the criteria for a mental health disorder.
Okay. What made you decide to start the Next Door? What's the whole purpose? What are you hoping to achieve with this?
Well, the Next Door started now 5.5 years ago, but
Mm-hmm.
the process started more like 7 years ago.
Okay.
This building here was sitting empty for about 3 years, and the organization that owns the building finally decided we're just going to try to lease it to a nonprofit.
Mm-hmm.
So there was a needs assessment done. There were some huge gaps in the community, and they talked with over 40 different agencies in the community.
Wow.
I mean, it was extensive
Huh.
over those couple of years.
Uh-huh.
And they said, what do we need in our community? And over, what kept rising to the top of that list was housing and services for women coming out of incarceration.
Okay.
And, now 5.5 years after the program has started, that was an understatement.
Mm-hmm.
I mean, has filled a significant gap in our community.
Mm-hmm. And why did you become interested in this?
Well, I actually started as a consultant on the project in
Mm-hmm.
that first couple of years of the early planning stages. I was at the Mental Health Cooperative, where I was the Director of Emergency Psychiatric Services.
Okay.
And I got a call from one of the women who was really enthusiastic about starting a program for women coming out of prison, and someone had given her my name and said, why don't you call her and ask her what kind of mental health needs and substance abuse needs are they going to have when they come out of prison. And they came to meet with me, and I thought, I'll never see these people again. I said, do you really want to know? Because all they had intended to do is provide housing for the women.
Okay.
So for 6 months, they were going to provide housing.
Mm.
And so it was kind of an afterthought from some well-meaning people to go, well, I wonder what their needs are going to be like for mental health.
Sure.
So I said, if you really want to know the truth, I'll tell you. And so after about an hour and a half, they had big eyes, and I don't know what we have gotten ourselves into. I mean, it was hilarious. So I said, all right, that's what you've got to do. You've got to have some really strong assessment, screening and assessment process. So
Okay.
you know who's in your house and what their needs specifically are going to be.
All right.
And also you've got to have appropriate programming. Otherwise you're just going to be a warehouse for people.
Okay. So these women are coming out of jail, out of prison.
Right.
They are essentially, they need a place to live as, I guess, as a transitional process.
Mm-hmm.
And what you've identified is that many of these women have had a history of substance abuse problems.
Right.
In fact, maybe that's one of the reasons they got into the prison system to begin with, or the jail, and also some mental health issues as well. So if you could just tell us a little bit about how you go about assessing women for problems that they have. They've come out of jail. Tell us a little bit about that assessment process, how that all works.
Okay. Well, the actual offenses that they were convicted of and sent to prison or jail, about 72% of those same women are there for drug-related offenses.
Okay.
So, I mean, that hunch is correct.
Mm-hmm.
And in fact, it's probably a little bit higher because there are things like forgery, robbery, theft, that they may be doing to get money to obtain drugs, but it isn't necessarily directly related to a drug offense. It's not
Right.
a drug charge.
Correct.
So that's probably, the 72% is probably low.
Right.
So most of the women, when they come to us, very few of the women have actually had treatment before.
Mm-hmm.
So when they come here, they, many of them will find that, we count their first day of clean time the day they get here.
Okay.
And they'll argue with you about that. Well, I've been locked up for 15 years. I'm not going to use drugs.
Mm-hmm.
But, in a confined setting, it's a little bit more challenging to find access to drugs.
Sure.
So that the DSM-4 allows for in a confined setting is significant here. So now if they're coming from the county jails, and we accept women from all over the state, if they're coming from the county jails, they typically are serving less than a year sentence in a jail.
Okay.
But if they're going to prison, it's typically 12 months plus a day or more.
Right.
So those who come from prison typically have more clean time than someone coming from a jail.
Mm-hmm.
So the assessment process is challenging because you've got some who've probably used recently and some who have not used in years.
Okay.
So the only way to really do that effectively is to do an assessment that's thorough from the beginning and do the same assessment for everyone.
All right.
So we use what we call the Behavioral Substance Abuse Profile, the BSAP.
Okay.
Within the first 48 hours of them being at the next door, one of our clinicians sits down face-to-face and does a BSAP. Some people may be more familiar with the Addiction Severity Index, the ASI.
Mm-hmm.
This is like the ASI for co-occurring disorders, in a sense. So
Sure.
it really pulls out more of the psychiatric piece or psychological stressors as a part of this assessment. From there, a treatment plan is put together based on their needs.
All right.
And given that most of our women end up with a co-occurring disorder, a co-occurring mental health and substance use disorder, we have to put a treatment plan together for both disorders at the same time.
Okay.
That are addressing their stage of recovery in both areas.
Now, I've heard that some people have the philosophy you treat the substance abuse issue first and then the mental health issue. And I know that there are different positions on that. What's your opinion along those lines?
My experience drives my opinion.
Okay.
And my experience from crisis, when you see people coming in and out, same people over and over again. And you hear the mental health people saying, if she just stopped smoking crack, she wouldn't need us anymore.
Right.
Well, if she could just stop smoking crack, she would have just stopped smoking
Sure.
crack. So, just treating the mental health piece does not touch the addiction piece. If you're the sequential system of treating one and then the other, by the time a person gets out of A&D treatment, like an inpatient or residential care, 28-day, 30-day program, old school says they took them off all their psychiatric meds in order to come into that program.
Right.
So you can only imagine for someone who has major depressive disorder, recurrent and severe, what happens after 28 days of not being on their medication.
Exactly.
Now, they're not using drugs,
Right.
but it's only a matter of time. So as soon as they get out of that treatment, they go out and they start medicating.
They're feeling awful. They want something to treat the pain
That's
or the
right.
unhappiness or
They
whatnot.
are miserable clean. So they go out and they start medicating. So, the cycle starts all over again. They become suicidal, as a result of their deep depression. They may attempt suicide, or they're saying, I'm going to commit suicide if I don't get help. They end up back in the mental health side. So it's like a cycle that never ends. So I subscribe to the philosophy of co-occurring disorders, where they are two independent biological brain diseases that have to be treated as two independent biological brain diseases. So when I am mentally stable I don't have the great need to go out there and use and medicate because I'm not feeling depressed as much. I'm not as anxious. You know, if I'm anxious or depressed, I'm going to go out there and medicate. Now, if I'm out there using, you know, I'm not worried about my medication. So again, I start the cycle all over again. So I've found great success, great outcomes. You know, and everything is episodic. I mean, you know, you have to expect people are going to relapse in both their mental illness as well as their addiction. And, you know, we just meet them where they are, you know, and use motivational interviewing from there to try to help that person realize they've made some progress. But this is just the bump in the road. Now let's get back, you know, get back on course and move forward from here.
Because you want to keep the motivation going.
Keep the motivation going, because many times they begin to feel like they're the ultimate failure. A relapse is a shameful experience for them, and there's a lot of guilt. So, you know, if you can engage them quickly after a relapse, you know, particularly in mental health symptoms, and try to get them back on their medication, it's amazing. One of the first things I have learned to ask is when a woman relapses, I ask, when was the last time you had your medication? And invariably, the answer is, you know, I don't remember.
Interesting.
And, you know, I've finally got the staff trained to ask the same question. But the real trick is to get there before they just stop taking it. So, but many times they don't like the side effects of the medication. Women in particular, very conscious of their weight and the way they look. And many of the medications cause, you know, significant weight gain. So instead of talking about it with a provider to look for other options, they just stop taking it. So, you know, those are all things we're learning.
So looking at just a typical counseling session for women who have the co-occurring disorders, would you be addressing both the substance issues and the mental health issues in one counseling session? Might it work out that way?
Yes and no. It really depends on what the treatment plan is saying. You know? And in that, you know, when we sit down with a client in the therapeutic relationship and we set goals, and the client says, this is what I really want to work on now, and you negotiate to get to that point. You know, I really want to work on feeling depressed, or I want to work on my self-esteem is a really good example. And so, you know, my thinking there is, so let's work on your self-esteem and talk about the role that alcohol and drugs has played in helping you get through those days when you have experienced low self-esteem. So everything we do ties back to the drug use.
You're linking those two things together.
In fact, we've developed some trauma intervention groups called, one of them is sex abuse recovery, another is grief and loss recovery, and they're both based in, you know, you're here to talk about an event or events when you were traumatized in a sexual way, and, you know, so people coming into that group know that's what we're going to be talking about. They have screened into the group. So when we're in the group, every session we're talking about the role alcohol and drugs has played. You know, how it's made things worse, you know, and the insights that come through that. So at the end of the group, the goal being that, you know, I have this moment of realizing I don't have to medicate those feelings. I've had them supported. I've had some normalizing with other people in that group, and I understand I've got some coping skills now that I can get through, you know, any re-experiencing of these, you know, that event or those events. It's more often that our women have had multiple events of sexual abuse. So, you know, they hopefully at the end of the group realize they don't have to medicate that. Because they've got skills now and other ways to look at those events. So that's how we do the co-occurring piece here. And, you know, with co-occurring disorder, you have to focus on anxiety. Anxiety is really the tipping point for people who have both ends. So when there's an anxiety event or a stressor that's causing anxiety, we try to get there at the first sign of anxiety. And, you know, I can tell that you seem a little stressed today. What's going on with you? Or are you okay today? And so we try to get it before, they become secretive about what's
because
bothering
their pattern may have been to medicate
Exactly.
in the past when they felt anxious.
Exactly.
Okay, so you're trying to nip that in the bud.
As soon as
and
you
teach
see the
them.
anxiety, you deal with that
Okay.
anxiety. And, we're finding really promising results with that.
Interesting.
So we're becoming anxiety agent. I guess
Okay.
we're our own anxiolytic. we
Sure.
don't. The women can't have benzodiazepines in our program. So we don't subscribe to medicating the trauma away, because the trauma is stored in the body and it's still there. So when I don't take my Xanax, I'm becoming anxious again.
Sure.
So we try to deal with what causes the anxiety.
Well, that you bring up an interesting issue, because if they don't have that as their substance of choice to deal with the anxiety, do you find that any of these women become dependent on you as the treatment provider, almost like you're the anxiety agent?
Well, that's an interesting question.
Mm-hmm.
I've never thought about it that way. I'm sure there is, to some degree, some level of dependence, but that may actually be coming from the fact that they're clean for the first time, many of them, for any period of sustained sobriety.
Right.
So it'd be hard to say if it's because of that intervention or it's the fact that they're in a safe place where they are clean.
Sure.
And so I think dependence is always a risk factor.
Okay.
And, we have to be very careful, and the more skilled clinicians are better at that, honestly, and being able to say, anything you got from this program, you did all the work. I mean, I gave you some help along the way, but you did it. And, continuously giving back to them, I like to say it, catching them doing something good, where they got a raise at work today. It's a house-wide celebration.
Sure.
Focusing
on positives.
on the positives, because coming out of the correctional setting, that negativity and is reinforced.
Exactly.
So, in a sense, I think we become a breath of fresh air.
Exactly. Sure.
For them. So, I think the risk of being dependent on, people that are kind to them is
Sure.
real.
Well, just a few more things, and then we'll wrap it up. One of the things that we do in our program is teach our students the importance of setting goals as part of the counseling process. And I think sometimes students learn about that. They think, okay, this is important, but yet when I get out there, I'm not going to do anything. I'm not going to have anything to do with goals. How important are goals as part of the treatment planning process at the next door?
They're huge. And I think I probably was one of those students at one point, and who thought that, that's all good, but when I get out there, it's not going to be like that. In fact, I don't think we emphasize goals enough. Goals for people particularly who have co-occurring disorders. If you're working with a person who's learning to live in recovery from alcohol and drugs, they count every minute. That's a goal.
Sure.
If I can just make it 5 minutes without going out there and using, that's a goal. So we don't realize the populations we're working with, how specific goals are to them. And true also with people who have mental illness. My goal would be to take my medication every day this week. And the thing about goals that's important to remember is that they have to know your population.
All right.
And they have to be negotiated with the client.
Okay.
If the client doesn't buy into it, the goals mean nothing. If I set the goals and when a client says, I want you to just tell me what I need to work on, that's a whole different issue.
Yeah, there's no buy-in.
No buy-in,
Yeah.
and they're not gonna change. So why waste their time and my time? So really building that rapport from that first moment, and it makes goal setting much easier.
Sure.
So when we're setting goals, it gives women a reason to celebrate. I did something I didn't think I could do.
Right.
To me, if somebody says, if I were to say, I went 30 days without drinking a cup of coffee, that would be huge for me. I mean, that would be hard
Sure.
for me. But imagine if the same, someone else sitting next to me saying, if I could just go 30 days without popping a pill.
Yeah.
If I could just do that, because for setting that goal, it's a huge goal for her,
Right.
that starts with maybe that first week going a whole week without using a pill.
Right.
And then we stretch it out a little bit further, and you know, those goals are in context way bigger than we think sometimes. Because for my population, not using those pills means not going out and committing another crime.
Right.
And if she's not committing a crime, she's not going to go back to prison. And so, I mean, it starts a cycle.
Right.
So keeping in context the value of a goal and goal achievement, and if they're continually not meeting that goal, then it wasn't probably a good goal to start
Right.
with. So back up and start again, and we have to do that sometimes.
And it sounds like it's such an important part of the whole transition process to make that transition for them successful.
They need to feel good. They need to feel like they can do something.
Yes.
And that they can do something well.
Right.
Even if it's small. But it's small not to them. It's huge.
Right.
Because,
Exactly.
you know, when most of our women were homeless at the time they were picked up and using at the time they were picked up. So when you're trying to teach them responsibility and structure, that's very challenging for them.
Right.
They never wore a watch. One of the women told me that the only time she ever woke up was when her crack pipe fell out of her mouth and hit the hardwood floor. So
Wow.
the noise would wake her up and she'd realize she wasn't smoking, and she'd go right back to smoking.
Yeah.
So that's the kind of day they had. That became night and day and night, and they had no concept of time.
Sure.
So, you know, reintegrating them into a structure, which includes goals,
Right.
you know, it's really important because you're retraining them their thinking. You're
That's right.
teaching them how to think all over again.
Well, just to wrap this up, Cindy, in terms of this whole transition process, does the Next Door coordinate with other agencies to help them go on, take the next step? And maybe you could give us an example of an agency that you work with.
Yes, we are actually a partner with the Board of Probation and Parole. So we have a probation officer who's assigned to work just with our women. So, you know, we put in our guidelines that we have a handbook for our women that come in the Next Door, and we say, we're a partner with your parole officer. So we're not going to keep secrets from your parole officer, and they're not going to keep secrets from us. So that leverage helps us keep women in treatment. So that partnership is critical because we know what's going on and they know what's going on. So we're kind of triangulating but working together in a positive way on behalf of that client.
Right.
We also partner with graduate schools like MTSU. We consider them partnerships. We have students now who are graduate students doing internships with us from Vanderbilt School of Nursing, as well as a Vanderbilt Human Development Program, MTSU, TSU, Fisk, Lipscomb, Argosy, and Trevecca.
Wow.
So we've just filled our new intern class for this coming year.
Okay.
So we really believe in intern partnerships because our women get fresh ears, new people eager to learn, and the women are eager to teach. So it's really been a great experience.
That's great.
We partner with Siloam Family Health Clinic, who treats a lot of our population who have no insurance, and they provide all of our medical and reproductive health care for our women at the Next Door. So
nice to have those kind of resources.
Oh yeah. Those are some examples of our partnerships.
Right. Well, Cindy, thanks so much for spending time with me today, and wish you luck in your work with the Next Door in the future.
Thank you very much. Appreciate it.